Greetings again. We have discussed now about the multidimensional nature of pain, and by the very fact that it is multidimensional, there will be multiple people who are involved in the management of pain. And therefore, it is necessary for us to understand the role and responsibilities of a physiotherapist in this multidisciplinary team dealing with people with pain. In the old approach or in the traditional medical model, what used to happen was a patient with pain used to initially come to the doctor. The doctor would identify the structure or have a tentative or hypothesis about the possible structure, and they would be sent for imaging or other medical tests, and then eventually they would come to the physiotherapist. If the physiotherapist was unable to deal with the painful condition, they went back to the doctor. In the multidimensional model of pain, where we are saying that all pain is not necessarily due to structure, this route need not be followed. So we might have people with chronic pain coming directly to the physiotherapist, who does an assessment, and if there are red flags or any reason that it would not be within the purview of the physiotherapist to manage them alone, they would send them to the doctor. So what this has shown is that this can decrease the cost of care. It can decrease the cost of care both in terms of dollar cost as well as in terms of time spent. And it is also identifying or recognizing, acknowledging the fact that pain need not always come from structure. Australia has something called a national pain strategy. And this emphasizes, the APA, Australian Pain Association, emphasizes the importance of the national pain strategy. And its 5 goals are that chronic pain should be recognized by policymakers as a disease by itself and not as a symptom, and that people in pain must be considered within the public health priorities. Then that interventions must focus on education, empowerment and support of people with pain, and not just curing pain or looking at it from the structural point of view. That professionals are adequately facilitated to provide best practice evidence-based care, which means each individual discipline within the multidisciplinary team needs to create its own evidence and come up with best practices based on consensus. That people with pain must have timely access to an interdisciplinary care, and it must not go through the traditional single route path starting from the primary physician. And that the importance of quality improvement processes and evaluation of outcomes and adequate findings of clinical, social and economical research, appropriate dissemination and implementation of evidence must be recognized. So these are very core components that deal with any disease by itself, and the APA has suggested that this also be considered for pain, and consider chronic pain as a disease in its own right and not as a symptom of some other underlying disease. So coming to the role of the physiotherapist in acute pain management. In acute pain management, our primary role is to ensure that the acute pain does not become chronic pain. And that the pain by itself is stopped right there. So, and that when the tissue heals, pain goes away. Where pain is considered as a symptom of the disease and it does not go into chronic pain, and there is no central sensitization or any other psychosocial factor that is coming into play, which can potentially convert an acute symptom into a chronic disease. So in acute care, we need to do pain education. Pain education means how to control pain, teaching the patient how to perform function without exacerbating the pain or without provoking the pain. So prevent pain provocation. And this is true in immediately after surgery. Post-surgical pain can often become chronic pain. So, or even in acute injury or on the sports field and so on. So, pain education is an important aspect even in acute care. Then assurance, to tell them clearly what can actually cause more tissue damage, and that the pain that they are feeling is a protective mechanism in this phase, and it need not be something that they fear. So that would be assurance, comes as part of education. And advice on resuming normal activity. Activity or movement, motion is necessary for physiological changes which can help the person to manage the pain appropriately. So rest is no longer advised for pain unless there is a large trauma, in which case they would naturally not be coming to physiotherapist at that time. So advise on resuming normal activity, again without provoking pain but without fearing pain. So this would be another role that we have in the acute care. Then discussions of options for pain management as needed. So every patient may not require the same amount of pharmacological management, but in the acute situation, acute pain requires pharmacological management. There is no reason to avoid pharmacological management because pharmacology is the first option. And but they must also be told that positioning and movement within limits of pain and other aspects, the psychosocial aspects, distraction techniques, etc., can be useful in managing pain. Management techniques such as manual therapy should follow international best practice guidelines, and this is where your clear assessment and identifying those people who are likely to benefit from manual therapy or other soft tissue procedures must be done. You do not do K-taping on everybody that you see. You do not do manual therapy on everybody. There are clear guidelines, or this can backfire. If you do manual therapy procedures on someone who is not a candidate, it can potentially cause further damage rather than help. So this would be the role in acute care. European guidelines recommend intensive multidisciplinary biopsychosocial rehabilitation with a functional restoration approach, utilizing graded exercises and activities, like I already told, education about pain, modification of unhelpful beliefs and responses such as catastrophizing and depression. So all across the world it has been understood that in the acute phase itself we need to cut short any sort of unhelpful beliefs that they may have about pain, so that the pain does not become chronic. Now, coming to role of PT in chronic pain management, you will notice that I have not used the term subacute, because in pain we are considering acute as until tissue has healed. So that is the acute phase, and the chronic is when there is no tissue damage that is visible but the person continues to feel pain, chronic or persistent pain, whichever term that you would like to use. So in such a situation where the pain itself is a disease, the role of the PT would be to classify based on red flags, yellow flags and so on. Find out if there is a psychosocial component, find out if there is a social component, and find out if there is any other underlying comorbidities which may make it a complex pain diagnosis. So if there is an underlying complexity or an underlying systemic disease, then this would require more than just the physiotherapist. It is necessary for us to classify. And this classification is based on best practices of assessment and management. Incorporating the biopsychosocial approach for physiotherapists requires a great shift in perspective and review of personal beliefs, because even though we have been talking about biopsychosocial model of pain, we continue to consider pain as a structural fault, and we continue to focus on intensity of pain using the VAS and NPRS as our major assessment methods, and this is simply not enough, because it is necessary for us to understand it, and studies have proven that those therapists who follow the biopsychosocial approach have greater results, have better results in terms of managing patients' pain. So education, continuing education of physiotherapy is also required. Educating the patient is required. Improving function, activity and overall quality of life should also be a focus in chronic pain, and not just decreasing pain in the short term. Promoting self-management or self-efficacy. Chronic pain is it is chronic, so it is not going to go away suddenly. So for this, self-management, whatever social beliefs or religious beliefs they have, can all come into play in improving the self-efficacy. So these are aspects of management that a physiotherapist must involve in dealing with a patient with chronic pain. When we are talking about education interventions can be discrete or they can be intensive, depending on the extent the assessment reveals that the patient holds maladaptive beliefs about pain. So our basic home program is usually do this exercise, do that exercise, do this exercise. And we normally, traditionally, we have always said if it increases your pain, stop doing it. Now this is no longer appropriate because we need to be able to identify if there is any sort of fear avoidance behaviors which can potentially be compounded if we give them such instructions saying that when you have pain, don't do it. Because we are giving a sort of unsaid or covered instruction that movement is causing pain. So you have to be very careful about what kind of education you give. So these interventions can be discrete. What you need to do is you need to guide the patient through activity, guide the patient through movement, and make them understand, this also falls as part of cognitive functional therapy, and make them understand that it is not going to increase their pain, except in certain conditions like rheumatoid arthritis for one, and so that the patient does not have wrong beliefs about their pain. When beliefs are maladaptive means unhelpful beliefs. That is a sign that either it can be because of extensive tissue damage that we have not understood, red flags, or it can be fear of movement, yellow flags, or it can be pain catastrophizing. So pain neurophysiology education is an important first step. So pain neurophysiology education, there is a lot of information on it, and we need to be able to first understand the neurophysiology of pain and then teach it in a way that the patient can understand to the patient so that they have better self-efficacy. PNE for patients with chronic or persistent pain addresses the physiology of pain in contrast to the biomedical approach. It is not showing, like we used to do in the back school, we are not showing the spine with the, an animated version of the spine with during bending that the disc is bulging, during extension that the disc is going back in. Those kind of things we are not doing because these have been shown through research to create more maladaptive beliefs. So PNE talks about the biopsychosocial model of pain and not about the biomedical approach. So we are not saying that it is the disc that is causing the pain, it is this that is causing the pain, and bending is going to increase the pain, straightening is going to relieve the pain. These are things that we do not teach anymore. The goal for PNE is to help the patient to revise their understanding of pain, to recognize and accept that their pain experience is not tied to actual or potential injury or harm, and it could be a sensitization, and that a lot of it could be happening at the cognitive emotional level. And to increase or improve physical activity and function based on that understanding so that they can break the fear avoidance or catastrophization cycle. And this will help them to promote self-management, including setting goals for themselves, which is an important step towards cognitive behavioral therapy. So the key components of PNE are learning about pain. When you understand why you hurt, when you know why something is happening, you hurt less. That's always the case. For example, if whenever we are going to a new place, it seems like the journey is too long, but when we are returning, the journey always seems to be short. Because you already know what the end is. So knowledge is like that. So if you know what is the reason for my pain, so if I understand that once this tissue heals, it is no longer going to hurt, then I have greater control. I have a feeling that I have more control over my pain. So because of that, the intensity or the experience of pain becomes less. Because like you have to realize that pain is not only structural, it is also at an emotional level. Pain is normal, it is personal and always real. So you cannot minimize someone else's pain. If the person says I have a VAS of 10, then the person is feeling a VAS of 10. Pain is a response to what your brain judges to be threatening. So if you can rewire your brain to understand that this movement is not threatening and that it is not going to increase my pain, then they will not feel the pain. There are danger sensors, not pain sensors. Pain sensors only happen in acute pain, and in chronic pain there is no pain sensor. It is a danger sensor which is happening at a higher level. Pain and tissue damage can exist in the absence of each other. This is what we say. Some people have high pain threshold. Even if there is a big cut, they do not say that they are in pain. Whereas other people, even with the cuticle damage, they may not use the finger for a long time saying I'm in pain, I'm in pain. So pain can be there without tissue damage, that is at the central level, or there can be tissue damage and the patient does not feel pain. That is depending on the person. It can also be a pathological condition like leprosy or spinal cord injury, or it can be because of congenital absence to pain, but I am talking about people without any other underlying neurological condition. Pain depends on the balance between factors that threaten the body and those that promote safety. So, this is intertwined with knowledge and beliefs. So, if the person feels that when I walk I'm going to have more pain, then they will feel more pain. Whereas if you can, if you say if they are made to believe that sitting still is going to make them heal faster, that is what they are likely to tell you for aggravating and relieving factors. Pain relies on context, that is on the current situation. So if they have other stressors, pain can be more. For example, all of you would have felt that a toothache is much more severe at night than it is during the day when you have other things to do. But at night when everyone is sleeping and you are awake, then you feel sorry for yourself and the pain becomes more. And beliefs, other beliefs, if you have maladaptive beliefs, then that pain experience can be worse. A nervous system can adapt to become more or less sensitive. So it depends on us to train our nervous system to react faster or react slower. Unless, of course, it is allodynia, hypersensitivity and all those kind of things. Active treatment strategies promote recovery rather than passive ones. So these are the key components of PNE. So now based on your patient and the patient, education, attitudes, beliefs, what kind of personality they have and what is their reason or what is their area of chronic pain, you would tailor your education, pain neurophysiology education, but they must have these components in them. Self-management addresses assessment findings related to factors that limit the patient's confidence in actively managing pain autonomously. Now, this is especially true in India, where we have this passive recipient attitude, where we want the doctor to cure us or we want the healthcare professional to cure us, and we are not really willing to take much responsibility for our own health. So this becomes all the more important for us to emphasize this factor. Some of the primary principles in chronic disease self-management may be applied to individuals living with chronic pain also. These are some of the principles that we use with diabetes, hypertension and so on. That is that acknowledgement that you may have to live with the condition. It may never go away. So it is here to stay, so I have to live with it. I have to learn how to cope best, so that will improve coping strategies. This is very true in patients where there is likely to be pain all the time, like rheumatoid arthritis, positive or trigeminal neuralgia and so on. Positively managing the condition, not limiting yourself because of the pain by fear, but rather respecting the pain, doing what you can within limits of pain and still trying to have some amount of quality of life. Optimizing physical and emotional health to minimize the effects of the condition. So the distraction or having, doing things that they like can decrease the pain experience. So these are some of the things that some of the aspects you have to teach during self-management. For improving function and activity, you use the graded activity process. So just because you think it is because of poor activity, you don't tell them to go run a marathon the next day. You need to select a meaningful activity, that is where the patient has to be able to set a goal that is meaningful to them and that they believe they can do. So you ask them, how much do you think you can walk? So if they say, I can walk about for 10 minutes. Okay, then you start with 10 minutes. And then you say, why don't we try for another 2 minutes? And if the patient is willing, and if they go for 2 more minutes, you see, you can do more than you thought. So that can, not in a judgmental way, but in a positive manner. So that these are some of the things that you would do. And you have to grade the activity process. So you have to measure the tolerance to that activity along with time, distance, or pain scale, or rating of pain, self-rating of pain, anything like that. And then you start at a starting point that is below that activity tolerance. Like if they say 10 minutes, do not start at 15. You start below that or at that. And then each week you gradually increase the activity for which you have to have patient-centric goals. So you need to sit together and say, I agree to start at, I will walk for 8 minutes, and then the next day I will continue to walk for 8 minutes. After 3 days, if I do not have increased pain, then I will walk for 10 minutes. And by next week, I will be walking for 15 minutes. So once they agree to that, it becomes a verbal contract, and then you continue with that. Recommend an activity range to enable some flexibility based on how one feels that day. Especially in chronic pain conditions where there might be good days and bad days, you cannot say that if you don't do the same thing every day, then I'm not going to come see you anymore. Nothing like that. You tell them, okay, let's see if you can work between 5 minutes and 8 minutes this week. And then if they manage to keep it at 8 minutes the whole week, then you say let us try between 10 and 12 the next week, and so on. So give them some flexibility, some ability to change, so that within that week they have met the goals, but they do not need to be consistent every day. All this will help in improving coping strategies, self-efficacy, and their feeling that they have some control over themselves. Exercise prescription, structured exercise interventions must be specific to the condition. Certain exercises will be local, some of them will be general. Again, you have to find the starting point that the patient is comfortable with and not what we believe is right for them. And then you need to slowly grade it up, progress it upwards. So there is something called exercise-induced hyperalgesia. So after exercise, we also call it DOMS. So after exercise, they may have increased pain or increased sensitivity to pain. But this can go down. If a structured exercise program is not something that the patient wants, or if it is a condition like fibromyalgia where you do not want a local exercise, then you can consider overall activity like yoga or tai chi or dance or whatever it is that you want. Now, to find patients, what does a physiotherapist do when they're managing patients who demonstrate maladaptive patterns of behaviors? First of all, you have to recognize that your actions have not precipitated the behavior. It should not be because of a clash between the therapist and the patient. Then you have to manage their expectations. Don't give guarantees or promises. Don't tell them, oh, I have seen patients like you and I always get them better in 3 days. I can get you better in 3 days. So don't make such promises because you do not know how they are going to react. Outline the treatment process and expectations, including discharge criteria. Don't tell them that you can stop coming when your pain is 0. Tell them when you are able to manage your pain, and when the pain is something that you can still continue your activity with, that is the point where you will stop coming to me. Avoid language that prompts acceptation or rejection of ideas. Don't give them options. Don't say, one possibility is that you may need to come for 2 weeks. One possibility is that you may need to come for 1 week, and that you may never be better, etc. So then the patient may not have trust in you. It is necessary to have therapeutic trust. Understand that the patient may see the therapeutic relationship as contractual. That is, if you they're paying you money, so they expect to get something in return, and that you need to cure them. So this is something that you have to understand, so that you communicate in a manner that will not allow you to fail. Now, how does the physiotherapist work with other healthcare providers, or what is the role of other healthcare providers? A pain specialist physician should be involved if the physiotherapist observes treatment failure after trial of 4 drugs for neuropathic pain, an opioid dosage greater than 180 milligrams morphine per day or equivalent, inadequate response to non-specialist management. So if the person who has referred the patient is a general physician or a surgeon or a pediatrician or whatever, and these things are not working, then you must consider referring them to a pain specialist. You should consult or refer to psychology or mental health professionals if the assessment or treatment reveals that the patient has moderate to high levels of stress and difficulty adjusting to life with pain. So if you are failing in what you consider is a correct period by which this patient should be showing positive gains, then it is time for you to start thinking about referring to someone else. Refer the patient to a multidisciplinary pain clinic if there is evidence of declining functional capacity or moderate to high levels of stress. So to summarize, intervention strategies where physiotherapists will, in almost all cases, physiotherapy, education is a key component, and so also in pain. So education is a key component where pain neurophysiology is specific to conditions. For example, if it is CRPS, specific to CRPS must be done. and whatever the condition is. Sleep hygiene, as we talked about, graded motor imagery, if it is required. This is basically for CRPS or other neuropathic pain syndromes. Sensory integration of somatosensory re-education, paced graded activity, respecting baseline symptoms, proprioception balance training, functional activities, quality of life restoration, specific, that's repetition, I'm sorry, pacing planning, for example, in rheumatoid arthritis. So depending on, so these are some of the intervention strategies you would tailor it to your patient. Now coming to pain experience at different stages, there is a 4-stage model of pain processing that has been proposed by Price and Wayne. In this model, the term stages refers to separate levels of processing that could occur simultaneously, although earlier stages give rise to later stages. So that is, stage 1 is the pain intensity, stage 2 is pain unpleasantness, stage 3 is pain suffering, stage 4 is pain behavior. So pain suffering can be negative beliefs, give rise to negative beliefs or negative emotion. So based on this, you have pain behavior. So pain intensity can be like if you cut your finger by cutting vegetables. So you have pain, but it is not an unpleasant situation which is not going to, normally it is not going to be emotionalized. But in certain cases, it becomes unpleasant. So they think about it all the time. So unpleasantness is when the pain becomes, you're thinking about it all the time. Pain suffering is when your activity and when your behavior has changed because of the pain, which along with the beliefs that may happen and the emotions can give to pain behaviors like fear, avoidance, catastrophizing, etc. In the initial stage, there is temporal, sensory discriminator comprised of spatial, temporal and intensive features of the painful sensation. Second stage of pain processing, termed immediate unpleasantness, reflects an individual's immediate affective response, that is your cognitive response, and involves limited cognitive processing, emotional response. Third stage of pain processing is cognitively mediated by an individual's beliefs and reflects their perception of the real or imagined long-term consequences of having chronic pain. So this might be, oh, my father also had back pain, and so I'm also going to have, and after he was diagnosed with back pain, he never worked. So these are some of the beliefs that that can happen at the third stage. Fourth and final stage is that of overt behavioral expression, that is wincing, crying, not getting out of bed, not grooming oneself, and so on. Now, there are certain special groups of people who may have different experiences, and one of them is the elderly. The elderly with painful conditions, self-efficacy may be reduced because of other factors related to aging, because as you age, one loses control over one's own environment, and so this can also affect their self-efficacy. So they may have had a very high threshold in the younger days, but as they grow older, this may not be possible because they may not feel in control of what they can do. So fear of medical or pharmacological interventions is there in elderly, especially with the media hype about problems of medicines and etc. So they may believe that it will cause gastric irritation, and so they may refrain from taking pharmacological interventions. Age-related perception of pain. The elders feel pain more than when they are younger. Belief that older people cannot tolerate opioids, like I said. Failure to think beyond traditional regimens. Older people are usually set in their ways, and they believe that if you go to the doctor gives you medicine and you become better. So they may not be accepting of cognitive behavior or self-efficacy and so on. Sensory discriminative and motivational affective component of pain. This diagram shows what this is. Now, when we talk about central sensitization, the stimulus-response relations in the spinal cord relates to the afferent activity induced by peripheral injury, triggered by a long-lasting increase in the excitability of spinal cord neurons, profoundly changing the gain of the somatosensory system. This you all know about acute pain. The central facilitation is manifests as a reduction in the threshold, or this can lead to allodynia, an increase in responsiveness or prolonged after effects of noxious stimulus, which can lead to hyperalgesia, and a receptive field expansion that enables input from non-injured tissue to produce pain. This can be secondary hyperalgesia. These are all theories of how central sensitization works. Central sensitization is a change in the functional state of neurons and nociceptive pathways throughout the neuraxis caused by increased membrane excitability and synaptic efficiency or by decreased inhibition on this system long after the structure has healed or tissue healing has happened. Coming to referred pain, pain felt at a site different from the injured or diseased organ or body part is called referred pain. The dermatome rule is when pain is referred, it is usually to a structure that developed from the same embryonic segment or dermatome as the structure in which the pain originates. This is called the dermatomal rule. So this is necessary before you say something is referred pain. So there should be a dermatomal logic, otherwise you cannot call it referred pain and you might call it secondary hyperalgesia. This is the way to differentiate between the two. The convergence of projection theory is the second mechanism for referred pain, which may be convergence of somatic and visceral pain fibers on the same second order neurons in the dorsal horn that project to the thalamus and then to the somatosensory cortex. This is called the convergence projection theory, where if you have pain in the gallbladder, you have disease in the gallbladder, you feel pain between the shoulder blades. Sites of referred pain, however, are not always stereotyped. Although we know generally where it is, sometimes unusual reference sites can occur. For example, angina can sometimes feel referred to the stomach. It can sometimes, to the abdominal region, it can sometimes refer to the right shoulder rather than just the left shoulder. Although predominantly you have certain sites of referred pain that are recognized, but it can potentially also refer to other places. We need to understand that. Primary hyperalgesia is an increased sensation of pain or discomfort produced by minimally noxious stimuli due to damage to soft tissue containing nociceptors or injury to peripheral nerves. This is what all of you would have learnt in CRPS. After a cutaneous injury, hyperalgesia can be found in the area of injury, that's primary hyperalgesia, or in large uninjured area surrounding the injury site called secondary hyperalgesia. Primary is characterized by enhanced pain to both heat and mechanical stimulus and is thought to be due to sensitization of primary efferent nociceptors. Secondary is characterized by enhanced pain to mechanical but not heat stimulus and is thought to be due to sensitization of the central nervous system. Allodynia is a painful response to non-nociceptive stimulus. Again, you would have learnt about this in CRPS. But this cannot always be used in the clinical setting because it is difficult to identify clinically whether the stimulus is capable of activating nociceptors in the individual patient. Because the pain perception is very different in different people, it is very difficult to identify allodynia clinically. This diagram tells you what is allodynia, what is hyperalgesia, and what is normal pain. The interaction between pain and motor function, studies have shown that brain imaging techniques have shown a complex network of cerebral structures associated with the different dimensions of pain, including primary, secondary, somatosensory, insular, anterior cingulate, prefrontal cortices, and thalamus. So when you say that a person with pain does not have structural damage and he's just faking it, that is not true. He's not faking it. He's actually feeling it as brain imaging shows. Vicious cycle theory and pain adaptation theory are two theories. The vicious cycle theory says muscle activity increases in a stereotypical manner in pain regardless of task, yet sustained activity leads to ischemia and accumulation of analgesic agents producing pain. And this can cause greater muscle activity, greater difficulty with muscle activity, and this can go on in a cycle. Pain adaptation is activity of muscles that are painful or that produce a painful movement reduces during voluntary efforts, whereas that of opposing or antagonistic muscles increases. This adaptation reduces the amplitude and velocity of the agonist muscles, and it forces and decreases the force produced by the muscle, leading to some amount of decrease in function that can again go back into the greater work in the antagonist and so on. To summarize, there are several mechanisms work to produce pain. Pain cannot be explained using only a stimulus response framework. Current research increases the scope and variations in pain perception and underlying mechanisms. It is crucial for us as part of the healthcare spectrum to understand the multidimensional nature of pain so that we can have better results with our patients. Research shows that PTs who consider the multiple dimensions are more successful than those who follow biological model alone. Thank you.